Welcome, everybody. My name is Agnes. I am the brand manager at RMA of New York. We're a fertility clinic based in Manhattan. We're so excited to welcome you to this webinar tonight. I think you're going to hear a lot of great information from informative and very smart individuals tonight. So get excited for that. We're going to give everyone just a couple more minutes to join and get acclimated. But we'll probably start in about 4 or 5 minutes. But thank you again for joining. We're really looking forward to this evening. And if you have any questions throughout the course of the webinar, feel free to put them into the Q&A box at the bottom of your Zoom screen. And that's where our moderator, Stephanie, will be able to access them. Thank you so much. Okay, why don't we get started? And if more people join, which hopefully they will, they can trickle in slowly. But again, I want to welcome everyone to tonight's webinar. Thank you so much for attending. Really looking forward to hosting you this evening. We have a wonderful panel of experts tonight who are going to be sharing a lot of really great information. If you have any questions, please drop them into the Q&A at the bottom of your screen, and our moderator, Stephanie, will be handling that throughout the course of the webinar. And so we look forward to tonight's conversation. Stephanie, I'll let you kick it off with introductions and the panel discussion.
Thank you, Agnes, and the whole team at RMA and Sharsheret for putting this together. It's an honor to be here moderating this conversation. I do this professionally all over the country, but this is actually it might be sort of like the most personal conversation I've ever moderated. And so it's a real honor to be here tonight. I'm going to introduce my fabulous panelists, and then we're going to talk a little bit. And then, as Agnes mentioned, we will take all your questions. I think you will have a lot of questions. I'm already seeing them in the Q&A box. So feel free to add them throughout, and we'll get to them. We'll get to as many of them as we can. Let's start. Doctor, we'll start with you. Dr. Matthew Lederman is a board certified reproductive endocrinologist and fertility specialist. He serves as practice director of reproductive medicine associates of New York Westchester, serving patients throughout Westchester County and New York's Hudson Valley region. Dr. Lederman sees patients at RMA New York's White Plains, Mount Kisco Fertility Clinic locations. Welcome, Dr. Lederman.
Thank you very much for that kind introduction, Stephanie. Good to see you. And thanks for doing this.
We will get to that. Melissa Rosen is the Director of Training and Education at Sharsheret. She holds a master's degree in Jewish communal service from Brandeis University and has been working in the nonprofit sector for over 30 years. At Sharsheret, Melissa oversees community education throughout the country, as well as the training of healthcare professionals, Jewish professionals, and Sharsheret's volunteers. She also manages the Community Partnership Program. She is a breast cancer survivor herself and is passionate about the Jewish community and cancer support and advocacy. Thank you both. Melissa, thank you.
Thank you so much. It's a pleasure to be here.
And I guess I'll just sort of start with what brought me here to this Zoom. First to Dr. Lederman's office many years ago, and then to this Zoom tonight. And it all actually starts with my wonderful mother-in-law, Wendy Cohen, who is on this Zoom tonight. She's here watching from New Jersey. And right after my bridal shower, my mother-in-law found a lump and was diagnosed with breast cancer and went through a lot of treatment. Obviously, she's amazing and she is fine here today, which is incredible. But from the beginning, we sort of knew that something about that was before our wedding. And as we sort of started to think about family planning, the thing that had happened was that Wendy was tested for BRCA as an Ashkenazi Jewish woman with breast cancer. And she was positive for BRCA1. And what that meant was that there was a 50% chance that one of her children would have it. She has a daughter, my sister-in-law, Sarah, and a son, my husband, Ben. And we were all really worried about what would happen if Sarah had it. And she did the test, and thank God it didn't have the gene. And then Ben did it, and he was sort of an afterthought. Because we were so worried, we sort of know this so much from the female perspective of what it means to have that diagnosis and sort of all the things you have to sort of do. Of course, Ben ends up as a carrier, BRCA1 carrier. And what that meant was that when we started our, family planning journey, things looked a little bit different. It meant that we sort of went straight to Dr. Lederman, actually, who had been recommended to us from the genetics clinic he had been to for his testing. And we sort of ended up in his office and we said, what do we do here? This is the beginning of our journey. Is this something that have you seen this a lot? Is this, we were a little bit unsure of what we were supposed to be doing. And so what he ended up walking us through was IVF for genetic testing, where we did all of the regular stuff that happens with IVF. And he can sort of go into that in greater detail. And he actually probably can use the right words to describe all of this. But what we did was we tested all of our embryos when they went out for chromosomal testing, for screening. They also got tested against this probe that was built with Ben's saliva and both his mother's saliva, that was really designed to look for, again, I'm going to let you explain all of this, but basically to see which of our embryos were BRCA carriers. And the math was quite real. 50% of all of our embryos throughout the whole process of IVF all had BRCA. Like, it really was the exact statistic we were presented with really showed in the reality of our experience. And so what we were able to do was select embryos that did not have this gene mutation and that also didn't have any chromosomal deficiencies. And those are the ones we implanted. And so as Dr. Lederman knows, because he met them this summer, I have two beautiful, healthy baby girls who both do not carry that gene. And I think, it's quite an emotional thing. I mean, it was quite a clinical process, but it's an emotional thing. I mean, my mother-in-law, the fact that these two granddaughters of hers do not carry this gene, that we've done something concrete to make sure this won't happen to anyone else in our family. And so it was, a bit of a different process than we were expecting. I never really thought about whether I would have to do IVF. That sort of wasn't in my brain. We weren't a traditional fertility case, I would say. But that's sort of how we got to you, Dr. Lederman, and how we experienced the IVF process. And it's to this day, it astounds me how incredible that was, that we were able to do that. I know that my daughters, I mean, you obviously can't factor out everything, right? Things can always happen, but the idea that there was this real we saw it 50%. We saw these what they the road they could have been down, and we were able to sort of stop it is really quite miraculous. And so I'm grateful for you, Dr. Lederman. And I sort of want to ask you what it was like to sort of see us from the other side. You know, when we walked into your office, our concerns were different, I imagine, than a lot of the fertility patients that you treat. So can you explain how cases like ours fit into your practice more broadly?
And thank you, Stephanie, for sharing your amazing story. And one thing I just want to just mention before we get going about, this kind of situation is, breast cancer, BRCA is something that is very dear to me. And the reason it's very dear to me, it affects my family because my wife's a BRCA2 carrier. So this is something that is very personal to me. I've been an advocate for, her story goes that, her mom, who had a family history of cancer, decided to get tested. And it turns out, she never had cancer, but due to family history, she came back being a BRCA carrier, had prophylactic surgery, mastectomy, ovaries out. And then we actually found out that she was BRCA positive a few weeks after we delivered my second child, my son. I remember to this day sitting, just sitting on a couch, and she told us, that she was BRCA positive and planned to do prophylactic surgery. My wife got tested, turned out she was a BRCA carrier. She ended up, having a prophylactic mastectomy, and then when we decided we're good as a family of two kids, she had ovaries and tubes taken out at the age of 40. So, I have a daughter who's a junior in college and a son who's a senior in high school who have a 50% of inheriting the gene and risks that come with it. So that's why this is something that's very personal to me. And something that I've advocated for, in terms of, bring attention to how it affects, family building. And that's where, looking back, when Stephanie came into the office, we see a lot of patients who obviously come to see us for fertility, recurrent miscarriage, but we also see a lot of patients to do IVF for genetic reasons. For example, when patient and partner both, say cystic fibrosis carries, and they have a 25% chance of having a child with cystic fibrosis. Or someone who has the BRCA gene and has a 50% chance of, passing on the gene and want to end the cycle by doing IVF and transferring an embryo that's BRCA negative. So we do a lot of IVF for genetic reasons, to prevent the child to be affected with a disease or a child at risk for, cancers associated with BRCA. So, and those numbers are going up, the number of patients we've seen. But genetics plays a big role, and when we see our patients before they're pregnant, one of the things they do carrier panels, which is a panel of 427 mutations. That's what the panel is of now. It includes things like cystic fibrosis, Tay-Sachs, sickle cell. Doesn't include the cancer genes, and we do this fancy panel, you likely have something and more than one thing. The key is you're not joint carriers. For couples who are lucky, who both joint carriers, who say have 1 chance having a child affected, they can do that special from IVF, which we're going to talk about. So we do a lot of IVF for genetic reasons, And just what does IVF even mean? So IVF is not something that happens 1, 2, 3. A lot of logistics and planning go into it. And patients do IVF at our program. We have a team approach. So they work with fertility care coordinators who help coordinate all the logistics, the schedule, when things happen, how to get the medications, how to do them. There's videos, authorizations for everything. Nowadays, with Stephanie, back then, they were just like paper consent forms. Now there's electronic models that patients have to do it before even signing these electronic consent. So we try to prepare our patients before it. Okay. And then with the period, one starts the stimulation shots, which are tiny shots get a little rapid, but not that bad to do. And what those shots do is cause multiple follicles to grow at one time. And we track one's response every few days with early morning bloods and ultrasounds. And those are quick visits during morning monitoring. So we try to get patients out, first thing in the morning. Most work. So we, get in, get out before work. Usually it's about 8, 12 days of shots, 5 or 6 visits, so it's not every day. And then when the ovaries, the follicles are ready, they take a special trigger shot. And then they undergo what's called the egg retrieval, which is 36 hours after the trigger shot. And that's done in the IVF lab. We have an anesthesiologist. It's IV sedation. So it's not general anesthesia. And while one is sleeping, using a vaginal ultrasound attached needle guide, vaginally puncture the ovaries into the thorax and take out the eggs. We cover our patients a little bit under an hour, and they go home a little sore, a little crampy. Usually on the day of the procedure, the partner gives an ejaculated semen specimen. And then we combine the sperm and egg in a dish, and we culture the embryos out. And when our patients do IVF, in this day and age, we don't transfer that embryo back in that same cycle. We biopsy and screen them as called PGT, or pre-implantation genetic testing. That's PGTA. We'll get to the PGTA, which I'll explain in a second. So PGTA is checking for aneuploidy, which is chromosome abnormalities. And at least, I tell our patients in our program, when you have a chromosomally normal embryo, it implants in the majority of cases about 60 to 70% of the time. So allows us to transfer a single embryo with high confidence. We don't put back embryos that have no chance from the start or one that's destined to miscarry. It doesn't completely eliminate it, but it greatly reduces it. And those embryos don't age, so you know exactly what you have for future pregnancies. Where age plays a role in all this, the older you are, the harder to get to an embryo, okay? So when someone does IVF, now your follicle that grows will have an egg. Now the egg will be a good egg. Now it will fertilize, grow, and make the screening states. There's lots of nutrition as long as you go, right? And age factors into this. The older you are, the less likely to be normal, okay? When we have a genetic thing that we're trying to screen out, such as the BRCA, we do what's called PGTM, which stands for pre-implantation genetic testing for monogenic disorders. The PGTM portion is for checking for that specific genetic mutation. Years ago, you would first create what's called a DNA probe, which is a marker for that genetic mutation. And that would require a DNA sample from the patient, the partner, be blood or saliva, and sometimes even additional family members. That gets sent to a specialized genetics lab, and they create the probe, and that could take up to 2 months, or in the old days. Nowadays, one of the companies we work with, they actually create the probe once they get the embryos. So they take the embryo, use the embryo DNA, the patient DNA, partner DNA, sometimes the family, and kind of build that probe once the embryos are, sent to them. And it takes about a month to get the first result. And then if they have to stimulate again, it's much faster. So the probe process is a little different, but you have to create a specific probe. And that probe allows you to look for the specific mutation of interest. In this case, the BRCA1, for Stephanie's husband, Ben, and then once, so like I said, there's so much attrition along the way to get a chromosomally normal embryo called a euploid embryo. Someone with a BRCA mutation, you're going to chop off 50% of those embryos. Not chop off, but you're going to eliminate 50% because of the way it's transmitted. So half the embryos are chromosomally normal, you may not want to use because it's going to be affected. So it causes even more attrition, And then once you have an embryo, in order to transfer it, the patient takes some estrogen pills about the lining. We have them return to the office about a week, 10 days later, evaluate the line looks good. We schedule the transfer for a week, start progesterone 6 days before. The transfer is done in the IVF lab. They're awake. We do an ultrasound on their abdomen, place a speculum, and then under ultrasound guidance, we pass a very tiny catheter through the cervix and release a single embryo at the top of the uterus. And the pregnancy test is 9 days after the transfer. Then we follow them early at the pregnancy to about 9 weeks or so. And one is on estrogen progesterone, which supports early pregnancy for a little over 9 weeks. So that's like a simplified version of how it works. And, so I see a lot of patients who do IVF for genetic reasons, and, I've seen a lot of patients who, have the BRCA mutation, What's interesting in Stephanie's case is that we did it for male BRCA. Men who have BRCA often don't get as much attention, you know, you know,
Mhm.
and the reason for that, the risk for cancer is much less compared to women. So men are still at risk for male breasts, metastatic prostate, pancreatic cancer, and skin cancer. But it's, not, it's an increased risk, but not as big as increased risk for women. Women with a BRCA mutation have an up to 80% risk of lifetime of breast cancer, you know, and depending BRCA1 and BRCA2, they have a increased lifetime risk of ovarian cancer. So BRCA1 could be a lifetime risk of ovarian cancer 40, 60%, BRCA2 less, about 15 to 30%. And that could be at an earlier age, you know, and that's where fertility and family planning is a major concern for many women who have a mutation.
Yeah, I mean, there's so many. I feel like every story is different. And what my story made everyone in my life realize was, oh, guys could have BRCA too. And I feel like, or BRCA1 or BRCA2 too. But I think that the takeaway is like there's so many different scenarios. And I guess I wanted to ask you, Melissa, like from your to tell us a little bit about Sharsheret, because as we mentioned, like there are so many other factors in this story. And the family planning, the reproductive sort of interventions are part of an emotionally charged moment for a lot of people in their lives.
Yeah, absolutely. So first, just very quickly, we can get into more of what Sharsheret offers a little bit later, but just so you're aware, we're a nonprofit organization that provides free, confidential psychosocial support to anyone impacted by breast cancer, by ovarian cancer, anyone living with a higher diagnostic risk. And today, of course, we're talking about those with a higher diagnostic risk, BRCA carriers or BRCA carriers. And here's the thing, the important thing. These are really big issues in a person's life, family building, illness, things like that. And when we're talking about issues like that, it's so important to realize that it's not just a physical thing that they're dealing with. There is a great deal of emotion that accompanies the physical treatment, the scans, the implantation, the shots, whatever it is. And it can definitely be argued that dealing with those are just as important as dealing with the physical aspects. In fact, academic study after academic study has proven that patients who have their non-medical needs met overall do better medically. So we're not just offering this kind of support to be as a kindness. We're doing it because very often it has impact on medical outcome. And so Sharsheret offers a great variety. Like I said, we'll go through that a little bit later. But you're right, you were talking about men, and they don't get the attention they deserve when it comes to issues of hereditary cancer mutations. In two different types, in two different time points that I can think of. First of all, this education. Women sort of, if they know about it at all, they know that they might be at risk for a hereditary cancer mutation. And they know that there are things they need to do once they learn about it. Even when someone is well educated, they seem to not want to integrate the information that men can carry these mutations as well. And right, men carry them in equal numbers as women do and pass them down to both male and female children in the same percentages that women do. But for whatever reason, it's hard to integrate. And so very often it goes unknown. Stephanie, you said your husband's test was almost like an afterthought. And I know that personally, when I've gone out and spoken, there have been several times that the host has said, please be sure to emphasize that men get these mutations, can carry these mutations. And I really am very clear about it. And afterward, when there are questions, I'll get comments like, well, thank goodness there's no cancer in my family. I mean, only on my mother's side. Wait, did you just not sit with me for a half an hour? So like I said, it is hard to integrate, but these screenings need to be done just as frequently with men and women, and they need the support as well, which sometimes is harder for men to access, just because of the society we live in. But Sharsheret does offer that support, whether it's talking to a social worker, a genetic counselor, talking to a peer support, as somebody who's been in that situation, somebody of the same gender who carries a mutation, things like that. So the help is out there, and we continue to push our education as much as we are able to.
So tell us a little bit about the mission of Sharsheret, and also what you do there.
Yeah, so my role there is as the director of training and education. I do a lot of community education across the country. This kind of education I was just talking about, teaching people how to be proactive about their health, how to identify personal risk, manage it, mitigate it, things like that. In addition to all that type of community education, I spend a lot of time educating healthcare providers about how to offer culturally competent cancer care. And when I talk about cancer care, I mean the entire experience, which is before a diagnosis, if somebody learns they're at higher risk, through long-term survivorship and everything in between. Because we know, just like we know that meeting a patient's non-medical needs helps, we know that providing culturally competent care is one of those non-medical needs. So we talk about that because Sharsheret is in fact a Jewish organization. Although I want to be clear that our programs are open to absolutely everybody. And when I educate about culturally competent cancer care, I use the example of a Jewish woman facing breast cancer, but I talk about it in the context of lots of different situations because everybody deserves culturally competent medical care. It really has an impact. And then the other thing I do is I actually train Jewish professionals about how best to educate and support their community about this. And that talks a lot about Sharsheret's mission in general. We are there to provide that education and support to get people through or to help them navigate their cancer experience wherever they are, and no matter who they are related. So we talk about not people facing cancer, but people impacted by cancer, which is not only the patient, and again, impacted by cancer here, we mean even learning they are carriers of a mutation. So not just the patient, but the partners, the spouses, the children, the parents, the best friends. And that's really important because they all have a critical role to play. All the more true when it's the partner who carries a BRCA mutation. You know, our genetic counselors at Sharsheret are really very unique. And while a genetic counselor you might speak to at a hospital is taking family history and ordering tests and screenings, we do take family history also, but they're really experts on the psychosocial weight of carrying a mutation, and what that might mean for a relationship, particularly when it's the husband who is facing that mutation, right? You know, it's their mutation, but they're asking their wife or partner to take on a lot of the load because of a mutation that they carry, injections and implantations and things like that. So there's some definite psychosocial things that are unique there as well. Some of the other programs we offer, in addition to for people who have cancer, who have been diagnosed with cancer, we offer peer support for many different situations. We have a moderated, a genetic counselor moderated Facebook group only for people who carry mutations, whether they've been diagnosed with cancer or not. And so the issues there are, and it's for men and women and people who don't have cancer and people who have had cancer and people who currently have cancer. And it talks about all these kind of issues. We also have an Oncofertility support group that is moderated by a social worker, so incredibly important. Because I think one of the unique things, and you alluded to this, Stephanie, when you said that your case was a little different, is people who are dealing with PGTM and fertility concerns because of a genetic mutation, they may not be infertile. And so the infertility space may not have the support they need. And they may not have cancer. So the cancer space may not have the support that they need. It's a very unique place to be. It can be very lonely, very frustrating. And so one of our things is this particular support group. We have a lot of other programs for those who in fact are facing, their family is facing cancer. But I think one of the most basic things is easy access to Sharsheret's social workers, to Sharsheret's genetic counselors, whether it's a one and done conversation or a long relationship built over many years. They are there for you, not to offer medical advice, but to listen to you vent on a difficult day, to connect you with resources, both Sharsheret's and other organizational resources, to help you plot out next decisions. We're never going to say, okay, this is your situation, you should be doing this. What we're going to say is, if you're considering PGTM, here are some questions to ask your doctor. Here are some things you should be thinking about yourself as you navigate this decision. And those are the kind of things Sharsheret does. Again, all free, all confidential, all uniquely curated to each person's exact needs. And in addition, available throughout the country and beyond. Big city, small town, equal access. And that's very important to us.
That's amazing. So let's talk a little bit more about oncofertility, this growing field. Dr. Lederman, will you tell us a little bit of the other, you talked about, a situation like mine, but there's a lot of like fertility preservation before chemotherapy. Like there's all sorts of options available for someone who is a little bit farther along past a diagnosis.
Yeah. So no, we also see patients who come into us and they come to us emergently, just diagnosed with cancer, and most patients we see in those scenarios are breast cancer, but there are other cancers too. And what's the problem with that is, most cancers require chemotherapy. And the problem with chemotherapy, it's very harmful to the ovaries. And it could basically knock out the ovaries and put them in menopause. And even if it doesn't put them in menopause and they still get periods after chemotherapy, it ages the ovaries and makes it harder to get pregnant. So that falls under the category of, as Melissa said, oncofertility. So in those cases, patients come to us emergently referred by their oncologist or other doctors, or just find us online. We get them in 1, 2, 3, and we'll stimulate them to freeze eggs or embryos before they undergo chemotherapy. And we'll start wherever they're in the cycle. We need about 2 weeks, and we coordinate the care with their oncologist, make sure it's medically safe to do. All we need is 2 weeks. And most of the times, the oncologist on board for us to freeze the eggs or embryos before they initiate chemotherapy. There's very few rare situations where medically they're unstable, and certain like leukemias where they're have a lot going on where we can't physically do it. For most cases, we need 2 weeks. We could freeze the eggs or embryos. They go on to chemotherapy, not long after, so it doesn't delay their cancer treatment, and it preserves the ability to have children in the future. And even if they're menopausal and they have frozen eggs or embryos, that's not a big deal in terms of how we could treat them. It's a big deal to them, meaning, but for us, we could give them hormones to help prepare the uterus, even if they are menopausal. So, those are, very tough cases and situations, because often, even someone who comes to us with, a pre-vivor, wants to freeze eggs, embryos, screen out the mutations, it's still highly charged. It's very emotional. This is taking up even more notches because they're worrying about coordinating, they have to get the poor place, they have to meet with all these doctors, there's so much going on, they have the family, whatever life, there's so much coming on at one time. It's very emotional. We get them in, we figure out how do we do it safely, and we freeze eggs and embryos to preserve their ability. The one thing I also want to mention, you said fertility preservation, and one thing that Melissa highlighted before is even patients who have a BRCA mutation or other cancer-genetic mutation who don't have cancer are often referred to as previvors, so a risk of cancers. Those are very complex situations. It's very emotional. So there's a lot of complex emotions that go into that. And what I've been trying to advocate is that someone who's diagnosed with, say, BRCA or the cancer mutation, who's a risk of cancer, they often meet with an oncologist, other doctors early on, support staff, but they also meet a fertility specialist, to discuss how their situation impacts them building the family in the future when they're ready. And that's very complex, and giving that information so they can make informed decisions, I think is also important. That depends how old they are. Do they have a partner? Do they plan on taking out the tubes and ovaries? Do they want to screen out that BRCA mutation? Because someone who's committed to screening that mutation out, they're committing themselves to IVF. It may make sense for them to freeze eggs or embryos at an early age, because the earlier they do that, they're more likely to get more eggs that result in chromosomally normal embryos that could then, remember, you're going to lose 50%, say the BRCA gene, to, then have embryos in the end to build a family. So knowledge is power. And, it's helpful, in my opinion, even if someone's in their early 20s gets diagnosed with BRCA, as a previvor, even though they're not thinking about the family at the present time, they should, in my opinion, meet with a fertility specialist to get, to be informed, to know how that impacts, to understand what the family goals are so they can plan accordingly.
Can I think that was great. You said something, I had a list of things I wanted to mention, but you said something that really triggered something within me. You said, and if they want to do PGT. And so I just wanted to emphasize that these are complicated decisions, like you said, and it's perfectly acceptable and wonderful that we have to do PGT, and wonderful that we have it as an option. But there are plenty of people who just as legitimately choose to have children and not do it through PGT, even if they are mutation carriers. And that's also a legitimate way to build a family.
There's no one size fits all treatment in these cases. It's so complex. What if, you may not want to, someone may not want to screen out the BRCA mutation, but they plan to take out the tubes and ovaries because they're 40, they're not done having kids and not ready to have kids, so they could still freeze embryos, not do the PGTM to screen it out, and have those embryos to transfer down the road when they're ready. And once again, they don't need ovaries. We could give them hormones to support the uterus and the early pregnancy.
Yeah.
So it's so complex. It's not a one size fits all. There's a lot of unique circumstances that affect decisions. And that's why just having the information to know what options exist may help one come up with an informed decision when it comes to family building.
And not everybody's lucky enough to have you as a doctor. So I want to say that if your healthcare team doesn't mention fertility preservation, don't assume it's because you're not a candidate. Go ahead and proactively ask, because very often they're so focused on getting treatment started, which they should be, that other things fall away. And so if family building is in the future is important to you, absolutely ask about fertility preservation.
It's so interesting. What you're both saying is reminding me so much of my own journey, because I do feel like there's a lot of noise. And I remember I would say, oh, well, first of all, once I told people I was doing IVF, or my mom would tell her friends. Turned out everyone was doing IVF. It just felt like, I mean, this was 5 years ago. I think it's even more open now, but like I knew so many people who had gone through it. Someone said, "Oh, here's my favorite acupuncturist. Go to her. Here's this." Like there were so many friends said, "Here's the Google Doc, the spreadsheet I keep. It's helpful to try." Like or use an ice pack. Like I got all of these tips from people once I was a little bit open. On the other hand, I was sort of saying to people, "Oh, I'm doing IVF, but it's for genetic screening," because I didn't want to put myself in, as you mentioned earlier, Melissa, like the category of people who were, fertility warriors, right? People who had gone through a lot of emotional and physical just road to get to where I was starting from. And so I wanted to sort of respect that. But then I'd also hear people be like, "You're doing what? You're screening what?" Like it was almost like you can't, there's like I was sort of bending myself trying to contort into what everyone else thought. And of course none of that matters, but I think it's hard because it is an isolating process in many ways because I mean, of course, you see a lot of people in the waiting room at RMA, and you sort of do this like polite thing, but we're all sort of there on our own. And so I'm so curious for you, Melissa, like how if this is sort of something you hear a lot, like the decisions, what you're saying, which is like making sure you're advocating for yourself in a clinical setting, and then also figuring out how to advocate for yourself in like all sorts of social, family, friend
Yeah.
settings.
We do hear it, not just with this, but with people who have been diagnosed with cancer too. This phrase like, "Oh, I don't have it as bad as so and so," or at least it's not that. And what we try and remind people is there's no hierarchy for challenges here. And yes, what we find is the place that you found yourself in, Stephanie, is isolating because there are established resources for cancer patients, and there are established resources for those going through infertility. And this space that you were in is a very new space, and we're just starting to get that. And what we are finding is that people feel guilty that sometimes in some situations that they're not dealing with what other people are dealing with, and they don't belong, they don't want to take up resources from someone who's actually struggled with fertility because they may be fertile, they're likely fertile, or they don't want to, share information, like you said, because they don't want to upset someone. And again, what we do here is explain, just like Dr. Lederman has said, like everybody is an individual and everybody has their own story, and one isn't better or worse than the other. But that's also why we're looking to create these spaces for this very unique group that deserves their own support, because these people are also dealing with challenges that would benefit support. We just actually put on our calendar, on Sharsheret's calendar, a webinar coming up at the beginning of June called "Finding Your Place While Navigating Genetics and Fertility," which is really all about this issue specifically. And we'll certainly make sure that everybody on this webinar gets information about that. But I think the most basic piece of advice is to maintain your agency as you're going through this, and know that you are allowed to take up space.
Yeah. One thing that, a patient of mine, taught me, many years ago is, her story, she got BRCA tested because her father had it. And, she would, got diagnosed in the early, mid-20s. And she did, she went every 6 months for, imaging. And, she, what I found interesting was, every time I went, it was so scary. I was, the stress of every visit. I'm clear, great. I'll be back in 6 months. Clear, great, back in 6 months. And then she finally was actually diagnosed with breast cancer in the late 20s. Caught it early, didn't need chemotherapy, and said, just surgery, no radiation, and said, I did everything I could do, prevent cancer. I still got cancer. I don't want my child to have to go through what I had to do, that crazy anxiety I want to screen it out so my child doesn't have to go through it. And that really hit me. You know, having to go every 6 months. That's what she chose. She wanted. She didn't choose. Prophylactic surgery. She chose. Screening, and that stress and anxiety every 6 months. That would. It would. She would schedule it. Would go. Brought up. A lot of anxiety. I was good this time. Go away for it, then come back. It's just like a vicious cycle, and it just makes these situations so complex. And like when you're in those scenarios, you can't even anticipate what you're going to feel. It's a unique situation that's so complex, and it involves like a whole team to really try and you know help one navigate that kind of situation, and a lot of support.
And that's why one of the things I'm so proud of is that our genetic counselors, like that's what where they really shine, where something you can't get elsewhere is helping people through living with the weight of carrying a mutation like this. And just as often as I've heard someone say, I watched my grandmother go through it, my mother go through it, I've gone through it, I am not going to allow my children to go through it if I can prevent it, which is very similar to the story you've just shared. I've heard people say, if my parents had chosen to screen me out, I wouldn't be here. And hopefully by the time my child is an adult, there will be a cure for cancer and
Or a
things like that.
vaccine. There's always
Yeah, yeah. So again, right back to everybody is so individual.
So we have a lot of questions coming in. I'm just going to start. Uh, would you be able to say, Dr. Lederman, what you tell patients who are BRCA 1 and 2 carriers about the chance of getting an embryo without a mutation? And
So
this, I know not to ask him a question like this after all our years
you can ask me anything,
together.
Stephanie.
I know I'm
Um,
not going to get the answer I want.
so once again, embryos that get to the biopsy stage, you know, 50% are going to be affected on average. So first you have to start, based on how old you are, right? Not every egg you get is a good egg. Now it will fertilize, grow, and make to the biopsy screening stage, right? Then it depends on how old you are, the chance of getting a normal embryo, right? That's age dependent. And then 50% on average of those embryos are going to carry the gene. And that's why someone who does IVF for BRCA, they almost need twice the number of eggs compared to someone who just has regular infertility, because you're screening out 50% of chromosomally normal embryos.
One of the things that I realize people don't always realize because they're not thinking about it is 50%, yes, but that doesn't mean that if you get 4 eggs, 2 will have and 2 won't have. Like sometimes they all have and sometimes none of them have.
Yeah. It
And
doesn't
I
always
have
follow.
found out that
I
the
was,
ones, sorry, I had 4 my first time, came back from testing. 2 of them had BRCA of the 4, so 50%. One of them was chromosomally abnormal, which was 25%, which was normal for my age, and one was fine. But that was just bad. Like sometimes later on, the chromosomal abnormal ones also had BRCA. So it was like the math could go either way in an even more sort of
you know,
frustrating way.
when you take, thousands of embryos, it's going to even out, right? But when you take only a few at a time, sometimes there's a little luck. I've had patients where they got a lot of normal embryos, but more were affected than you anticipate. Or the opposite. They didn't get a lot of normal embryos, but more of them were BRCA negative. There's a little luck involved with that. Things don't always go by the numbers with a small number. It evens out with thousands and thousands of eggs, when you take big numbers. So sometimes, things don't always play by the books with the numbers, but when you look at the average, 50% will be affected.
And so that question was about someone with BRCA 1 and 2. So I'm curious if that changes your answer at all. They
It
just
doesn't matter
clarified.
BRCA 1, BRCA 2. So, 50%.
And is it true that someone with BRCA 1 has a lower egg reserve when doing egg retrieval? And is there anything to help boost this? This person is close to 30 years old.
So that's a great question. So there's some studies out there that suggest BRCA carriers, and it's a little more BRCA 1 than BRCA 2, may have a lower ovarian reserve, kind of lower fertility potential in terms of markers of, when we look at the ovaries, what we call a follicle count. Another marker is called AMH. It stands for anti-Müllerian hormone. It's a blood test. So there are some studies that suggest more BRCA1 than maybe BRCA2 may have lower reserve. There's some studies that suggest that they don't. I've also seen some studies suggest that BRCA2 may have a low reserve. I've seen both sides of this. I've seen cases of young women, early 30s, who come to me, with a BRCA diagnosis, and you look at the ovaries, you don't see a lot of follicles. The AMH comes back low, and they don't respond as well. But you still could get an embryo that's BRCA negative and chromosomally normal. They just don't have a lot to work with. So my hunch is, when you look at BRCA1, BRCA2, there's hundreds of mutations within BRCA1 and BRCA2. I suspect there's maybe within that specific mutation, remember there's hundreds, some of those may be associated with a low reserve, but no one's really done that study because you need such large numbers. So I think there is a subset out there that may have a low reserve. It's not most, but even one who have low reserve, and I've seen a handful of those kind of patients, they can still be successful. It may take a little longer and more cycles to get an embryo, but they could still be successful. And there's nothing they could do to make it better, unfortunately. There's no like magic pill or supplement. But someone who that's why it's important to have these conversations at a younger age, the younger you are when they're having these thoughts, so we can test their, fertility, the ovarian reserve, and factor that into their decision-making tree.
We've also been asked the insurance question, which is basically, does insurance cover PGTM, the IVF with genetic testing? And then are there resources for financial issues dealing with IVF egg retrieval because that's not technically infertility? Curious for both of you.
Yeah. Melissa, I don't know if you want to start.
Yeah, I can start. I mean, that is definitely one of the challenges that a lot of the fertility organizations require you to be infertile to access their grants. So at the moment, we're constantly collecting updated information to share with our callers, but it is a challenge at the moment.
Yeah, it's a complex question because it depends on the insurance. Some insurances will cover the IVF. Some will say we cover IVF for fertility, but not for that mutation. There are others who cover it blanket. There are some fertility perks out there, that bigger companies partner with, companies such as Progeny, Maven, Carrot, just to name a few, and they offer fertility perks to employees, which include freezing eggs, freezing embryos, doing the PGTM, regardless of the circumstances. And those perks make it a lot easier because now you're taking away the finance out of it. That's not most patients. So now you have to go look at the basic insurance. And, what we do is we have, finance counselors who review the benefits, who, and then speak to the patient in terms of what's covered, what's not, So it's so complex. It depends on their insurance, their specific fertility plan. Some will, some won't. I wish more would because I think it should. There are some grants out there that may help cover the cost. When patients have cancer, there's companies out there that help fund. We work with a company called Chick Mission, which is an amazing organization that helps fund their cycles when they can't afford it. There are other grants out there. Patients at our program get discounts. But that's someone who's obviously cancer where things are emergent to try and defray the cost. So great question. It's complex. That's why we have finance counselors to try and review that. I wish more would cover it because I think it should be, because that's sometimes a big obstacle.
Interestingly for us, my first daughter was born in 2021. My second was born in 2025. But in that time, my husband's company had gotten one of the Progeny packages. And so a lot changes quickly. And he figured it out because he was talking to a female colleague, and he mentioned that we did IVF, which is a thing most people, like it just, he said it and it was sort of unusual for him to say that. And she said, oh, I'm on the guild. We actually just are like, we're negotiating for this package. And so it's like, it's sort of another a reminder to basically like seek out all these resources. And the more you talk about it and the more you know, advocate for it, there's a lot of these packages that your workplace can pretty easily, because that's a great way to appeal to, you know, new
Yeah.
employees. And yeah, is by
And
getting
more
these
companies
things.
are partnering with these fertility perks,
Yeah.
but it's more bigger companies. You know, there are some small companies too, which takes out the finance. It puts the patient in control, you know, to make, you know, their decisions, you know, and hopefully that continue to grow. You know, there are more insurances that cover IVF, you know, but some, you know, there's some exclusions. You know, they may not cover for this reason, but some do. It's so complicated, and you know, I wish it was easier. I wish everything was, you know, covered, because I think, you know, that, you know, patients should do what they want to do based on what's best for them medically and their family situation. You know, and you know, finance unfortunately play a role in that, and I wish that was eliminated, so that didn't, you know, prevent them from doing what they want to do.
So we have another question about having both BRCA1 and BRCA2. Is that something you see with people having both of those mutations? And have you seen someone who has had both mutations and has produced an embryo without either? I mean, with a unaffected embryo.
So personally, I've not seen that situation, but there are situations that exist where you have, BRCA1, BRCA2, and that puts risk of another thing called Fanconi's anemia. So that's a more unique situation. It makes it a little harder to obtain an embryo, but it's still doable, you know. But that's a, minority of the BRCA cases. But there, I've had some of my associates had those situations, you know. It does make it a little harder, and it adds another genetic issue, Fanconi's anemia as part of that. I don't know if Melissa, you have anything to add to that?
No, no. I know that's a question that our genetic counselors
Yeah,
get, but not being a genetic counselor, I
yeah.
don't know.
And we also have reproductive geneticists who just specifically focus on reproductive genetics, and they're wizards. We have two. They're some of the smartest people I know, and they're really nice. So our patients always meet with our geneticists to review their situation, and so they can counsel them in terms of further genetic risk and things like, give them, specific numbers,
We've been talking about some heavy things here, and I was hoping we could close by both of you offering, just a sort of a word of hope of what you've seen in your work, what's inspiring you, and what you're sort of transmitting to your, the people you work with.
Do you want to start, doctor?
Sure. So the fertility journey, whether it's infertility, whether it's a genetic reason, it's not always an easy journey. It's like a roller coaster ride with highs and lows, you know. And when I tell most patients, who don't have these easy journeys, most patients who persevere will ultimately get there. So perseverance goes a long way. It's not always easy, but with perseverance, most will obtain their goals. And so persevere.
That's great advice. I have been with Sharsheret for over 12 years now. And in all of the places that Sharsheret has programming, whether it's what we've been talking about today or cancer itself, in just over a decade, the changes I've seen that have in our programming, because medical advancements have required it, are really amazing. And in really such a short amount of time, we've had to change the support we offer based on medical advancements. To me, that is incredibly inspiring. And the other thing I'd say is I know that patients who seek out support, psychosocial support, emotional support, really manage their situations so much better. And so we are grateful to be in that space to be able to offer it.
And sort of having been on the other end, I'm grateful to both of you, not only for being here on this panel tonight, but for all you do for people like me and all the people who are in these unusual, unlikely, unexpected positions, and sort of need to figure out how to make it through. Melissa Rosen from Sharsheret, Dr. Matthew Lederman of RMA of New York, Westchester. It's been a real privilege to chat with both of you. And thank you for being here with us today.
Thank you for having us.
And thank you, Stephanie, for sharing your story, which I think is, you know, very impactful. And every story is so different. And thank you for sharing your story.
Of course. Thank you both. And thank you to RMA and Sharsheret for putting this on.
Good night.
Thanks, everybody. Thank you so much, Stephanie, for moderating, and Melissa and Dr. Lederman for contributing to the conversation tonight. It was just beautiful. I hope everyone got information that they needed. And if you need more or want to review any of the conversation that was discussed tonight, there will be a follow-up email tomorrow that I'll be sending out. It will include a link to tonight's webinar, as well as information on all the different organizations featured here tonight. So if you want to contact them further for more information, you can do so. I encourage you to. I hope you all have a wonderful evening, and please reach out if you have any questions and you're even just looking to learn a bit more information. Everyone here is always willing to help you. So thank you so much again to our panelists, and have a good night, everybody.